Episode 4, The Paradox.
Welcome to The Paradox with your attending, Dr. Eric Larson. He is a practicing anesthesiologist and clinical assistant professor at Michigan State University College of Human Medicine. Listen in as he takes you behind the scenes of what practicing medicine in today's ever-changing world is like with another doctor. The Paradox is a fun and accidentally informative show for physicians, patients, or anyone who has ever found themselves in a waiting room.
Welcome to The Paradox. I'm your host, Dr. Eric Larson. If this is your first time listening, thank you so much for joining me. If you're a repeat listener, thanks so much for coming back. And please recommend to your friends. Today's podcast is going to be different than the previous episodes. The first dealt with policy and sort of learning about different things that are going on in medicine. Today's will be a little more practical, I guess you'd say. There'll still be a bit of a story and finding out about direct primary care, but we're going to discuss how you go about starting direct primary care practice and figuring out exactly, when to start, what parts you need to do, and what resources there are. There are actually a ton of resources we're going to talk about today, so don't feel like you need to write everything down. It'll all be available on the show notes page at the end of the at the website, which is at www.theparadox, and that's paradocs.com, and just look under episode 4, which is the interview with Dr. Chad Savage. I'd recommend you also visit my Patreon page at patreon.com/theparadox. You'll find some bonus footage if you become a subscriber and just donate a few dollars a month to help keep the show on the air. You can get access to that, and I'll add more as more people join in. But it's at least a kind of fun little pilot, my first pilot podcast, I guess you'd say. And so it's kind of fun to see a little bit behind the scenes action and find a little bit more about my daughter, Catherine. Anyway, a final note about this episode. At some point during this episode, my microphones just kind of went crazy. Actually, it was mine. So you'll hear some weird staticky thing that goes on with Dr. Savage's microphone. His is actually pretty good, but the production quality definitely at about the 40-minute mark or so will definitely deteriorate a little bit, but it's still very listenable. I had to re-record some of my questions because they were really impossible. So once again, I learned a little bit more about GarageBand, a little bit more how to edit to it. So learning experience for me, but I think you'll still find the show very enjoyable and also very informative. I'm joined here today with my friend Dr. Chad Savage, who serves on the Michigan State Medical Society committee with me. That's how I first met him. We're in the regulation and legislation, which is as exciting as it sounds. We pretty much discuss, regs and legs in the state of Michigan, how it in fact affects healthcare and physicians and patients, and weigh in on sort of how the society should lobby the
just got done with that meeting, so need a shot of caffeine to get going.
Right, at least one, maybe a double espresso or something. That's actually pretty interesting if you're interested in policy, which clearly I am because I've got a podcast here, and I mean we're both sitting here, so clearly we're interested in that sort of thing.
Nerd hour.
Yeah, nerd. Yeah, well, although anything in medicine is pretty much nerd hour, right? I mean, I think it just depends on where you channel your nerdiness, and for us, it's also into policy, right? So the discussion today, we had an earlier episode on direct primary care where I talked to Dr. Amant, and I'll reference that in the show notes page today. Again, any links we use or discuss today, organizations, whatever, we'll have in the show notes page later so that people can find those. So you just go to theparadox.com and you should be able to get access to all that information. So the first question today is, Dr. Savage is a primary care doctor. Why don't you just tell us a little bit actually your education through residency and then your primary and your practice until you entered in direct primary care.
Sure. Well, I'm a Michigan native, so I grew up in the area. I went to University of Michigan for undergrad, and I went to Case Western down in Cleveland for my med school, and I went to Washington University in St. Louis for my residency before coming back to be with my family. I actually practiced an insurance-based practice for about 13 years before I decided to jump ship and go insurance-free in the direct primary care model.
And your residency was, I assumed, internal medicine?
I'm sorry, yeah, internal medicine.
Okay, right. So you went from Michigan to Ohio and then to Missouri and then back. So, and when you would say you use an insurance-based model for people who are listening here, obviously that is, we're going to talk about direct primary care today again, and then we're specifically, that's more where you leave the traditional, I'll say again in air quotes, the traditional healthcare model where you either are in private practice or you're within some sort of large health system. But essentially you use a third-party system where you're using either Medicare or Medicaid to pay the bills, or a private insurance company like Blue Cross Blue Shield or whatever.
Yeah, paid by something other than the patient.
Right. So the patient pays, or they work someplace and they get their coverage, and so that's how their bills get paid. They're not the ones making the transaction. It would be sort of like you hit a deer. We're in Michigan, so we hit deer all the time, right? So you hit a deer and, you go to the body shop and they pay, the insurance company pays the bill. You don't actually care oftentimes what the bill is from the repair shop. You might go to a reputable one, but you don't care if it's $2,000 or $2,500 because most insurances in Michigan, if you hit a deer, that's totally covered 100%. Usually.
Actually, there's if I can digress for a second onto that analogy, there's a fascinating analogy of the body shop and the difference of a third-party system and insurance-based payment.
And we're not discussing plastic surgery, by the way. So go ahead.
Yeah. So if you go to if you get in a car crash, you go to the body shop and non-plastic surgery, and the first question they ask you, they say, "Are you going to pay with insurance?" And if you say, yes, I'm going to pay with insurance, they usually go, oh, great, good, because you got this scratch over here on the door. It probably wasn't anything to do with the accident, but you're running it through the insurance company now, so we can take that door off, we'll repaint it, and you'll get, hey, it's all good, it's going through your insurance, don't worry about it.
It might have happened during the accident, right? Who knows, right?
Who knows? So you're happy because you think it got paid for by the insurance. Of course, who paid for the insurance? You did originally, so it does come back to hit you in the wallet. And they're very excited because they get to make this really big bill, and they maximize the bill. And you compare that to the non-insurance based approach where you come in now and they ask you the question, well, are you going to use insurance to fix your car? And you say, no. And they go, okay, well, we can just buff it out a little bit for you. It'll be okay. We'll give you 20% off. And there's a compassion understanding that you're paying for it. So there's an obscuration of the payment of the bill. When you pay it through a third party, there's this imaginary fallacy that it costs no one anything and you're not the one who actually pays for it, and yet you did in the premium in the first place. So it's interesting how it really coerces the care in many ways when you get this obscuration of the payment.
Sure. Well, and my wife and I moved to an HSA this year, HMO HSA insurance product, where you're buying all the medical your prescriptions and everything. There's no copay. And I mean, for the first time, we're actually not looking at just convenience of where we're getting our medication, but it's the cost. And so we use various apps to find out where where
it changes how you think about things.
Oh, absolutely, no question. I mean, and I mean, anyone who's involved in making the purchase versus not making the purchase, there's no question it changes your behavior. And I don't care how much money you make, there's definitely something that comes along with that. So anyway,
it's your money,
right? No, I mean, no question when you're part of that. So you've gone into you were in practice in sort of, we'll just say a traditional practice. And again, we're not going to mention any specific healthcare systems or whatever, because quite frankly, what we're discussing is no different anywhere in the country. I can't imagine it's really, when we're talking about the payment model, whether using a third-party payer or, which is again traditional, like either government payer or insurance company, there's no difference between that and in Tuscaloosa than it is in Augusta, Maine. It's all pretty much the same versus here in Michigan, the great state of Michigan, where we haven't quite hit spring yet. It's almost, it's mid-April now. So you moved to direct primary care. So how did you first hear about it?
Well, I was pretty enchanted by the insurance model, and I thought, so actually the beginning began with disillusionment. Mm-hmm. I went in, as many of us do, in medical school, and I was idealistic and thought how wonderful this noble profession we were entering into, and I really did believe it, and I, in many regards, still do believe it to this day. But then the actual practice I found was something other than that. It was very bureaucratic and paper, and it was not this wonderful interpersonal relationship, healing relationship that I envisioned. It is really, by Marcus Welby, encapsulated. It was this it was just very much almost a treadmill. And then I actually realized that it wasn't just a factory type feeling by mistake. It's actually now, in fact, very intentionally being designed that way. Six Sigma, I believe, is the name of it. And
the Toyota. Right.
Yeah, the Toyota approach, and where they actually were having auto executives come to try to help increase the efficiency of medical care. Well, that sounds great on the surface until you realize the model that they're trying to build it like is an assembly line, and very much felt like a worker on an assembly line. Well, I didn't forego the better wages of a subspecialty to become a primary care doctor to be an assembly line worker. I did it because I wanted to maintain those personal relationships, get to know people. That's the real value. The payment of primary care isn't always monetary. It's those relationships, and that was being squished out of my profession, thus defeating the reason I went into it. So I looked around, and I wanted to see what else is out there. And I saw at the time, and this was maybe around 2010 or so, that there was something called concierge that was starting to be come into vogue. But concierge was a little different in its design. They recognized that if you had 3,000 patients, and I had between 3,000 and 3,500 patients when I was an insurance doc.
And that's a full-time patient panel.
Yeah,
right?
That were the number of patients that were assigned to me that I had to provide care for. So these concierge docs had something unique. They had panels of around 500 patients, so they were able to give much better care. But recognizing the costs of the insurance-based system, they said, well, if we're going to take care of 500 patients and support this massive, infrastructure of a practice, 6-to-1 ratios or whatever, if I'm assuming that's what you're saying, we have to pay more or charge more.
Like so six times more, let's say,
six
right?
times more, yeah. So they would have to charge for like $3,000 just to have the opportunity to be part of that practice. Then they'd still bill your insurance company after that, still bill the individual co-payments for visits after that. So I immediately recognized that was not what I wanted to do. I don't begrudge anyone who does this, but that was going to be very much limited to the quite well off to be able to afford that kind of care. So then several years later, I stumbled on what Josh Umber and Lee Gross and some of the pioneers of the direct primary care movement were doing with direct primary care, in which they had accomplished essentially the same thing, having very small panels, providing fantastic care. But what they were doing were doing at a much lower price point by eliminating the costs of dealing with the insurance company. They just decided, instead of charging more to deal with your insurance company and see fewer people, we're going to take care really well of a smaller number of people, but eliminate the cost of the third-party payer system. So therefore, the insurance companies and therefore give concierge-like care, but do it through what was called direct primary care, meaning the patient eventually, just like in that auto shop example, is paying for that bill. They might as well just make it transparent, pay for it up front, and then actually pay less in the aggregate and get better care.
Right. So you're basically having people come straight to you, and they're just paying a membership model,
Yep.
and certainly in today, probably the economics are more in your favor, right? I mean, because probably 25 years ago, insurance was pretty cheap. There were hardly any copay. I mean, now you can say, well, I'm never going to meet this stupid deductible. I might as well have something where I can actually see someone and not, because my copays are more expensive than maybe this membership or whatever, right?
Yeah.
And we talked about this with Dr. Mott. So before we talk about the specifics, because the point of this interview is in many respects is going to be if I'm a physician out there listening right now, either one coming out of training or someone who's in established practice, how do I do this?
Yeah.
But the question before that I want to ask is, how has it changed your life since you've moved to that model? How your mood, your going to work, all those sorts of things?
Well, you probably can't hear it in my voice, but I'm smiling. And I joke, actually last time with Eric here at the last meeting, I said you knew who the direct primary care doctor was at the table because I was the only doctor smiling. So that's kind of encapsulates the difference. So actually it's funny, just to finish up the prior thought. So after I saw what Josh and Lee and some of the others were doing, people say, you immediately jumped on and decided to do it. And I said, no, I thought it was very interesting. I watched them for several years to make sure they didn't die.
Right.
Because I was convinced that it was so different from the rest of the system, though I immediately recognized the beauty of what they were trying to accomplish. It was so out of step with the rest of our system that I was convinced that it was not going to be a viable financial
that people
model.
wouldn't go for it, right?
Yeah,
I mean,
there's
right. It's not the way things are done. So you think, well, these guys are going to be with their hat out in the corner, right? Trying to...
Exactly. So then when I saw that they not only didn't die, but they were flourishing, I decided to throw my hat into the ring and give it a go. And here I am about 3 years later, and I'm very blessed. I have a full practice. I'm literally shutting it down to new patients, my own.
In full is how many?
And I have 700. Now, the average DPC doc usually has around 500, but I decided to use a slightly lower cost point, which meant I had to take on slightly more patients, but it's still, a fraction of what I was seeing in the insurance model.
And your pay has, not without going into specifics, is it changed?
Yes, it did go down, but not much. So, and in fact, I'm not sure how it's going to. Last year, I was still in, and I'll be open about it. I was a little over 200,000, which is pretty online for a primary care doctor.
That's pretty good actually for primary care.
Yeah.
My wife's a pediatrician, and they work for peanuts pretty much. But
yeah.
Compared to other.
So, I mean, I've had people, I've worked for a mountain bike. I've worked for eggs. So it is funny because people have kind of joked about that. Like, well, what can I pay in eggs? And I'm like, well, sure, whatever, bring them in, So, but there is almost a component of barter that's come back into this where I had one gentleman, I wanted a new mountain bike. He had a mountain bike that was wonderful he wasn't using. He said, can I give you that? Sure. I gave him a year of my service and he gave me a nice mountain bike, which I enjoy.
That's not a bad deal, right?
Great arrangement. But yeah, so it's but now that I'm maxed out, I wasn't maxed out last year. I'm maxed out, so it'll likely be above that. It'll be north of it somewhat, not incredibly, which will be pretty close. I was very productive insurance doc, but it'll be getting closer to what I made at that time. But the difference is, again, it wasn't about dollars; it was about happiness, and I was. To be quite honest, I was becoming miserable in what I was doing. I was burning out. I was starting to count the years to retirement, which is sad because I'm in my mid-40s, and at the time I was in my early 40s. And now I don't. My wife's a pediatrician as well, and she's still in the insurance model, and she is very much counting the days, and she keeps moving that date closer and closer. Mm-hmm. So she's a save-aholic for one reason, because she wants to get out. And it's kind of sad to think that way, but that's the way she thinks. She's like, I need to save as much money, make as much money as I can right now, save it all up so I can get out as quick as possible. And that's so sad, because it used to be as a doctor that, it was a noble profession. Not even my dad would do it, and my grandpa would do it, and it was multi-generational. Not mine specifically, but most were.
Mm-hmm.
Many docs are multi-generational because it was such a great deal. I mean, you got paid to take care of people. It was a double positive. It was a wonderful profession. Well, now it's more than half of doctors do not recommend, in fact, actively dissuade their children from going in the medical profession. So what happened? And I think it's that we sold our souls for a short-term financial gain. We sold our souls and gave up control and being the practice of medicine to third parties, which now, we act as marionettes and control us, and we dance around when they tell us to dance around.
Right, because, it was easier to get payment and more reliable. Because Medicare is only going to give you, they're going to give you dollars. They're not going to give you eggs ever.
Yeah, actually, the history of it's kind of interesting, because it goes back to the original Blue Cross Blue Shield, which were separate entities. One was for hospitalization, one was for doctors. And doctors agreed to these contracts with them because they said, well, so many people don't pay us. Well, now the bad debt rate is something around 60%. So it's like you collect 60 cents on every dollar, which means actually if you look at it historically, that's probably worse than what they originally were, experiencing when dealing directly with patients. And I can tell you from our own experience, though we, of course, have some people who don't pay their bills, it's quite a small fraction compared to what it was under the insurance model. And I've got this whole graphic, I call it DPC math, and it shows how when you pay at the time of service, you have much, much less bad debt. So essentially every dollar you charge, more of it is going to actual medical care.
Yeah. Well, and you have better eggs now. I mean,
and they're fresh and yummy,
right?
Delicious.
Exactly. So you went into DPC, and once you saw that it worked, and you saw guys, you said, I'm not going to starve. I'm going to be able to provide for my family, because I know people who are not physicians find this amazing. We actually have families. We have children. We have
who like to see us occasionally.
And when you look at the training for a physician, your primary care, you're done at age 30, right? If you go kind of straight through, you're done your undergrad at 22, you're done with medical school at 26, and for your residency, you're about 30. You may go into specialty or whatever, but some family practice maybe 29. But you're 29, 30 years old, and you're carrying a significant debt of about $250,000 now, sometimes a little bit north of that, depends if you had college undergraduate debt as well. And you got to pay that off, and you're you might be making $200,000, but you're paying off. You got a lot of interest and you got a lot of expenses and things like that.
And it can be a challenge because it's not immediately flip the switch, hang the shingle, as they used to say, and all of a sudden you have a full practice and you're making six figures. Unfortunately, it's a little like the old way of practicing medicine where people built a practice. Mm-hmm. So people who are thinking about doing direct primary care really need to take that into consideration, that there's a ramp phase. You can't expect, unless you are converting a very successful existing practice and you expect to retain a lot of those patients, there is a period of time that you have to ramp up. So you have to kind of budget for that. And it's interesting because there's two different approaches. Josh, I'll reference him again, Josh Umber. He came right out of residency.
From Kansas, is that correct?
From Kansas, yep. And he started his direct primary care practice. And he has an interesting take on it because it was different than mine. He says it's best to do it right out of residency. And the reason why, he says you're already used to living fairly.
You already know what ramen noodles taste like, right?
Yeah, exactly. Yeah, there's so that's a great way of looking at it because you're already kind of used to a tight budget, and you do have it for a little bit, and you can literally have no staff when you start with that kind of model. And in fact, I know one doctor who had no office when he started in that model. He literally did everything, just going to people's houses and all house visits until he built up a large enough patient census that he could afford a rental space, and he's got that now, and he's flourishing. He's down in Detroit. His name's Thomas, Dr. Paul Thomas, and from what I understand, he's doing really well down there. And you compare that to what I did, where I took an existing practice and converted it. In some regards, it's easier. In other regards, it's harder.
Yeah.
I started with more patients right off the bat. I had several hundred patients, with a lot of education and groundwork to make them aware of what I was doing, because it was still such a foreign concept when we first started. But I had a big head start, so I was able to start with a practice. But I also started with a mortgage, so I had to do that.
Right.
So there's I was used to the doctor's lifestyle at that point, not living lavishly, but having expenses that are set like a mortgage that aren't easy to modify. So there's different hurdles with different approaches, but there's also different advantages.
So all right, we have discussed where you start. I think, so your answer would be, it kind of depends what you want to do, right? If you want to come right out of residency and you say, this is kind of how I've seen that Norman Rockwell painting.
Yeah.
That's the kind of doctor I want to be. That's why I went into medicine. Yep. I want to have that, because medicine is not, I'm a specialist as an anesthesiologist, so I spend 5 minutes trying to convince someone that I will not kill them and that they will survive after the procedure. And honestly, I enjoy that challenge to get established rapport and putting people at ease.
And here you're doing a podcast. I thought you guys didn't like to talk.
Well, that's, it's interesting. That's probably why maybe I'm not meant for anesthesia. I wonder at times. Yeah, I came home from medical school and after my anesthesia rotation and told my wife, oh, this anesthesia is pretty cool. I think this might be what I want to do. And she just burst out laughing, assuming that I was joking, because she thought it was the most boring rotation she'd been in. She couldn't imagine anything worse than anesthesia, where you just kind of sit there and watch someone while they're sleeping, right?
My wife thought I should have gone in anesthesia. I always put her to sleep.
Yeah, well, I've gotten that joke many times. Yeah, right. All I do is pass gas and put people to sleep, right? So it really, you can come either straight out of residency, or you've tried the sort of current model, and you're like, this is just kind of not what I thought medicine was going to be, and I'd like to try something different. And like anything, right? If you're to some sort of, and it doesn't have to go to medicine. I mean, if you're having some sort of job somewhere and you say, I'm going to be open a business, you've sacrificed whatever income you might have had at your job, and now you're risking. I mean, it's a risky venture in some ways, right? You just have to trust that you're the type of person who's going to be successful in it, meaning people like you enough to come see you, right? I mean,
Well, I mean, it's interesting. People say, what's the first thing you assess when you want to decide if you want to go into something like direct primary care? And it's actually the first thing to assess is yourself.
The hardest thing.
Yeah, and you really have to determine your mental fortitude for it. Because at this stage, though it's growing rapidly, and the hope is that the pioneers who are laying the groundwork with direct primary care get it out of the unfamiliar range and get it familiar, because then it won't be such a harrowing task for people to consider doing it. But you have to say, okay, I will encounter some hurdles. Can I deal with that? Will I be able to adjust and adapt as challenges arise? And understand there's a huge movement in direct primary care of doctors supporting each other. In fact, that's why I'm here today. There's Facebook pages and things of that sort where there's a free flow of ideas and support. There's organizations set up to try to actively help people convert to direct primary care, like the DPCA, Direct Primary Care Alliance, which was recently formed with the primary intention of helping to guide doctors who are considering going into direct primary care. There's books out there. Doug Ferrago has a book for direct primary care talking about how to set it, and Kimberly Korba, another physician, both are physicians, has a manual with all the regulations and contracts and things of this sort. And these are huge starting points. I mean, we didn't have these things when I started. We were, laying the road to begin with. Now people can drive down those roads which have already been laid. So that's a huge start. That's a huge benefit. I mean, literally go from somebody like Lee Gross, who's one of the founders of the movement. He told me his initial legal fees of setting up the contracts were $60,000. Now, before you stop and stop the podcast, that is not what it is anymore. It had gotten down to about $2,000 by the time for all the legal forms and stuff to set up the practice. About $2,000 when I started. And if you're able to follow somebody like Kimberly's book, I think you can buy the book for like $500-$600.
I looked up today; it's $610.
Oh, okay, yeah. So. And I think if you're part of the DPCA, the Direct Primary Care Alliance, I believe there's a 20% discount. So, is
there a membership fee for that?
I think the first year, I don't believe there is, but don't quote me on that.
Because they know no one has money the first year, right?
That's right.
Smart. Okay, so I'm a doctor. I decided I'm going to take this plunge. We're not going to care if we're a resident or a current resident planning a practice, or we're established doctor. At this point, step by step, what am I doing now? So I've gotten the guide, or I've gotten some sort of guidance. Mm-hmm. So I have some idea, like for maybe forms and things like that, which, $600 when you're already $250,000 in debt. Yeah, what's that? $600, right? So what's the first step?
Well, probably figuring out a plan. I mean, you want to figure out where you're going, right? You can't go someplace, successfully without wandering unless you know where you're going. So you kind of make a long-term plan of what you want your practice to look like, and then you figure out in your unique geography how to overcome those hurdles. Do you need a physical practice? Are you going to? What's the rent going to look like? Because everybody's DPC pricing, the pricing for their practice, is going to vary a little bit based on what you want to make, what the cost of operating practice in your area may be. So you kind of have to get a little bit of data collection. So give yourself a little time to plan these things out. Don't do it in a hurry and do it poorly conceived. So there's something called zero balance budgeting, where basically you figure out how much you think something's going to cost to operate, and then you can put, for example, what you would expect to make on top of the expenses, and then you figure out how many patients you want to have. You divide that all by the number of patients, and there's your cost. That's exactly what I did. I knew how much it would cost to run my insurance-based practice. I took out the administrative costs of the hospital that I was employed under. I took out several other key aspects that were going to make it more efficient. I figured out how many patients I planned to see and how much I thought I should be able to make, and that's how I came up with my pricing points and my patient cutoffs.
So you looked at your salary, your endpoint salary, your clearance after expenses as sort of your goal.
Yep.
And so I want to take care of 600 patients, make X amount of dollars, so I need to charge this much per month.
Yep,
per
exactly.
person.
So I wanted to basically get back to a reasonable primary care salary. I didn't want to become a pauper doing it. I didn't care to be rich. I just wanted to enjoy the practice of medicine. That's how I came up with those numbers. Now everybody comes up with different numbers.
Sure.
Because if you're in a high rent district, you may either have to charge a little more per patient or see several more patients to cover that increased cost. If you're in a low rent district, it could be the opposite. If you decide to start with no staff, well, then pretty much anything beyond your direct operating expenses, your rent and whatever equipment you have, which in primary care tends to be quite low, then everything is salary. So almost all of their membership dues are coming to you in that setting.
And when I talked to Dr. Mott, her staff was zero.
Yeah.
She has just an office and takes care of everything herself.
And we're flourishing now. We have a 1-to-1 ratio, one staff to one doc. And I compare that to what it was before, and it was just astronomical.
She said she was 8-to-1. Is that kind of what you'd say is...
Yeah, it's funny. I think
because they're back office people and things people you don't see really.
Absolutely. I had one day before I left the insurance-based practice where I was talking to a patient about what I was doing, and we were talking about the massive overhead. And I said, "You're walking out tonight." It was my late night. So I was the only doc in this office. I said, count how many people are here. And there were 3 front staff, 2 back staff, and an office manager for me. And that did not include the hospital administrators who employed me, the billing and coding people who were off-site, and the HR staff and everything that the hospital had employed supposedly in support of my practice, and they did. And I liked my hospital system. I have nothing against them. But just from an economic standpoint, it was insanely wasteful. And I was taught a lie that the old model of a doctor and a nurse could not exist in this world nowadays because it's simply too complex. Medicine is advanced beyond that point, too complex. You can't do it anymore. Well, that's balderdash, to sound old.
That is very old. I don't think.
So yes, it was balderdash. Darn it. Because that's exactly what we're doing now. We have a medical assistant and the doctor, and we function very well under that model.
So your MA just like answers phones and sets up appointments and things like that if needed.
Yep, you got it. So she answers the phone and rooms the patients, and we do so much through remote communications now. So much is done through email and text messaging and things of that sort, which is wonderful for the patients because before they were by necessity had to go through a labyrinth to reach me. They had to talk to the front desk, to talk to the triage nurse, to send it to my MA, and eventually, if it was important enough and had gone through enough channels, it got to me. They had to do that because it was 3,000 patients, and I couldn't have direct contact with that many patients. But now with a lower number, they can directly contact me, and since it's very easy, just randomly replying to a text message like you would with a family member or an email in the same regard, it's quite manageable. People think, oh my gosh, it sounds terrifying, 24/7 access. Well, many docs actually have that right now. They just, they don't advertise.
Or it just piles up and they have 3 hours of straight answering stuff that they do right afterwards.
That they're not compensated for, and then are resentful for it because that's uncompensated time. They're answering phone calls and emails or through a portal, and it changes how you answer it through a portal because since you're not compensated for answering something remotely in a traditional practice, you're actually not incentivized to resolve it. You're incentivized to drive an office visit. Oh yeah, that sounds bad. Why don't you come in tomorrow and see me? Instead of saying, oh, can you send me a text message of that rash? Maybe I can treat it remotely, and resolve that problem, and you can go to work tomorrow and enjoy your day. And I handled it easily and efficiently. And
Sure, and from a medical legal standpoint, you may not know the patient as well as you have a handle on the patient population's 1/6 what it was, or 1/8, right? I mean, so you're going to know these people, like this person's. This is someone who is a very reliable source, and when they say they're sick, they're probably sick. Or this person's always saying they're sick, and they're really not. And so I'm not going to worry about it as much as
we recognize most of them by their face and know who they are.
Right.
And that's a big difference from before. We had literally someone who came in, we forgot to lock the back employee entrance, and somebody wandered through that today. And immediately, and I'm not revealing too much because I'm just saying a first name, hey, Kevin, why are you coming in that way? So, but we knew who it was, which was helpful because they were about to taser him. But no, I'm kidding.
That's the other thing, expense. You need to have a taser on hand, right?
No more tasers.
Tongue depressors and a taser.
And medical liability is lower too because that better familiarity for us, for them, but also for them, for us. So when we're able to give them longer care, we're able to show compassion and empathy, which is actually good. People are found to be more compliant when they understand their doctor is truly empathetic to their situation. They know that we're not doing things for ulterior motives because we're not doing it to try to facilitate a larger payment. It's a set payment.
It's all up front, right? We've already know it. All the costs are out there. There's nothing surprising that's going to hit them.
True transparency.
Right.
So they understand that when we make suggestions that they're truly for their best interest. So it really changes the practice of medicine.
And then, all right, so you've decided you have a target salary, let's say, and you figure out what your expenses are going to be, and that way you can figure out your charges and your patient panel size.
Yep.
That's kind of how you determine. That's your first. After you determine the location and make those determinations, and from there. So then you have to decide what your expenses are, right? I mean, because you have, how do you know how much you pay an MA? How do you know how much you need in supplies, for instance? Is that part of the manual that it has these supplies in it, and this many tongue depressors and this many Q-tips or whatever?
And actually, there's several different sources I hadn't thought of initially, but Atlas MD, which is one of the electronic record systems specifically designed for dark primary care, and not to push it too much. That's the one I use, but that's Josh Umber. He created that electronic record system. I'm a huge fan of it because that incorporates things like the emails and text messaging all within the EMR. But they have a lot of resources on that website. Anybody who's considering doing it, they have little tutorials as to how to start a dark primary care practice, and that's all free. And I'd encourage looking at that. But when I started it, they had a checklist of kind of common things that they did for their practices. So that was helpful to go and kind of look at it and price it out. And I'm an internist and he's a family doc, so not all of it, was the same. And I found... and you hear wild speculation of startup costs from various places, from people going from up to the hundreds of thousands of dollars, and I think that's just crazy. I was able to start mine for I budgeted $30,000. I think I spent about $13,000 to start my practice, and that included the legal fees and purchasing of equipment and things, because I kept it tight. And there's people who kept it tighter than me. You can honestly, if I had done it again, I would go to eBay and get an EKG machine off of eBay. I bought a new one. I bought a lot of new equipment, but my partner who joined me not too long ago, Dr. Cook, she's much more thrifty in that regard. We had to buy new blood pressure cuffs, and she went to eBay and got perfectly fine blood pressure cuffs, and we stocked our rooms with all these used equipment that were incredibly inexpensive. So be mindful of the budgets, in the early stages. But if you price some of those things out, you can start targeting a general idea of what it's going to cost you. And most of those are one-time expenses. You're going to pay them once, and then then you can figure out your ongoing expenses, which are going to be utilities, rent, staff if you have them, some accounting fees and stuff. Always get a good accountant, a good business accountant, have a good attorney to bounce things off in those early phases, who's used to establishing businesses.
So after you purchase your supplies from Uzbekistan off eBay, I'm sure it's all FDA approved. That's fine. And you've already determined the price. So you mentioned you've had a prior practice. So the next thing is, well, this is all great, except there's no one coming through your door. So how do you find people to come through your door? Websites, advertising, bullhorns. I mean, what sort of things do you do?
That can vary again based on, if you already have an established practice, the best source of new patients is your old patients. So if you're in a situation that allows you to recruit them, and that's unique because if you're in an employment arrangement... Most don't. Yeah. If you're in an employment arrangement, you may be prohibited from directly marketing to them. That doesn't mean you can't indirectly market to them through a billboard or newspaper ad, but most people find those to be fairly ineffective. Print advertising and some things of the sort, they'll always try to sell you on it, but you don't get a lot of people from that. The real selling point is you. If you're personable, if you're a good doctor, many people come to you regardless of price if you don't go nuts with your pricing points. But get out in the community, be involved. Again, this is what doctors used to do. They used to be very involved in the community. Now we're so busy, most of us are not. We're in our little cubby holes, and no one knows who we are other than when they come to see us in the clinic. We'll become part of a church group. You'll get a lot of referrals from that because they'll meet you and go, oh yeah, you're doing this. Oh yeah, this is a neat new thing. And, we work for you. We can save you money. We get the cheap meds, labs, imaging. Have a 30-second pitch. That's a weird thing to say.
The elevator pitch. Yeah. Mm-hmm. The elevator pitch, right?
Yeah,
you got to have the
elevator pitch. Absolutely. Because in that little 30 seconds, when people just say, hey, what do you do for a living? They don't really want a 30-minute description, so you have to figure out how to condense it into about 30 seconds to capture that. And some people will say, oh, that's interesting, tell me more. Great, now you've got it in. Some people will glaze over and, don't keep pushing it, enjoy them just as a friend, and they're not going to be a patient. But anyway, being involved, get your name out there. People will recognize you, and eventually, even if they don't immediately come, as you see them more and more at these family events, church events, chamber of commerce, charity, whatever it is that you're doing that's being active in the community, many will become more and more interested and start to see you. So be active. You could do formal talks. Again, chamber of commerce, great option for that. This is a new enough model that it does garner media interest to a certain extent. So, you'll have sometimes newspapers or radio stations that are interested in this model. Feel free to call into radio shows, mainly if the topic is healthcare, and have that as an option. It gives you more validity. It's funny, and you see this with healthcare in general. If somebody sees something on the TV, they'll see it. Well, this news anchor, this TV doctor said this, so it's true. But you can say, well, I have the same training. I've been saying that for years. You never listen to me. So there's something about being in a media source that seems to give people extra credibility. So if you become that person, immediately you become the authority in people's minds. And that can be free. So if you're contributing to local newspapers, TV stations, writing op-eds, whatever, we'll get you out there too.
Well, and if you look historically, that's how all practices are built, right? I mean, I think whether you were a surgeon, a specialist, or a primary care physician, I mean, you could be primary care coming into an established practice as a guy's retiring and you just pick up the patient panel, but I think probably lots of people would come to communities and they would have to promote themselves in some way. I mean, it's not probably newspaper or print advertising. It's you've established an office, someone gets sick, they look for someone and they find you. I mean, now, of course, with social media, there are other ways to find people. But the allure, of course, with working with large systems is that you walk into a patient panel already well established in a large referral network. Of course, the disadvantage is you've got to practice medicine in that model, and if that's not what you want to do, then that's a
lot of docs get stuck in what they call the golden handcuffs, because it sounds wonderful right off the bat. You can come right out, get 6 figures. We're gonna give you a retirement plan and all these other things, but before you know it, you're trapped. And it actually could cost you a lot of money. You could have no competes. There's a lot of things that could get you stuck in that model, and you could be miserable with the difficulty escaping it.
Right, and forced to relocate. If you have the no compete, like you can't work in this, especially for 1 year within 30 miles of any of our facilities. And maybe we're a regional center, so you've got to leave not only your community, but you've got to move 150 miles away or something potentially, right? So, all right, so lots of different ways to kind of build your practice. And do you have a website?
I do. Mine's www.yourchoicedirectcare.com. I'm not sure you need www anymore.
Yeah,
everybody assumes it.
Did you do it yourself, or do you pay someone?
I didn't do it myself. I went with a company who it was called Red Letter, and they with my input they set it up. But it wasn't. It was something that was there. That's probably there are other ones out there doing less expensive than that. There are a billion website development companies now, and most are quite inexpensive. That's a wonderful place for people to get access to you. And put a lot of information on that. I've heard kind of some references to make it work for you, and they're right. Put a ton of information on there so you can reference people to it. If you do videos, if you do talks, post them on your website, post your prices, describe the model. There are a bunch of other direct primary care websites out there right now that you can essentially copy.
Sure.
So, a lot of that verbiage is already put up there, so you don't have to recreate the wheel.
Right, and there are very few trademark or copyright restrictions on websites. I don't think there are any, really, for the most part. So that covers most of the startup costs. The other thing that always has intrigued me is the pharmacy aspect of it, because it never occurred to me that people other than pharmacists could distribute medications. And so I talked to Dr. Mott. She said, well, she can get like 1,000 lisinopril or something for $10 or something like that. Or it's very inexpensive, and then she sells them for 50 cents for a 30-day supply, which even though it's generic, it's still $4 at pharmacy. So how do you? What kind of drugs do you stock? How do you find the wholesalers, and how do you price things, and then how do you get a license?
Yep.
So that state, I imagine that's somewhat state dependent, right?
Very much state dependent. As I understand it, Texas, for example, you still can't do it. But in the state of Michigan, we're blessed that we can. And that was largely designed for the oncologists, because oncologists mainly are the ones administering chemotherapy and things of that sort out of their office.
Infusions, basically, in their offices is kind of what they
So it is legal in many states, and Michigan is one of them, for a practitioner to dispense to their patients with an additional license, which is not hard to acquire.
It's probably like $20,000 for this license, right?
No, actually, I think I don't remember what it was this year, but it's maybe like $80 a year or something like that. It's fairly easy to apply for and renew, and it doesn't take any additional, licensure beyond your medical license and what you've already done for that. So then there are certain requirements that you have to have with labeling and information about the drugs and things that go along with this. And the beauty of the direct primary care specific EMRs is that some of them, like Atlas, actually incorporate that into the product. So for example, if you have a Dymo label maker, which costs you about $60-$70, and the labels are a couple.
That's the one from Uzbekistan, or is that?
Yeah, well, no, for the nation of Dymo. No, yes, no, they're used for labels for just about anything, but you get them in a standard shipping label size, and if you wrap that around a pill bottle, lo and behold, that's the same thing Myers and Kroger and all these other places and CVS are doing. Essentially creates a label essentially identical to that, and then the program itself tracks your inventory, tracks dispensing, links it to the patient's chart. It's very easy. I was intimidated to do it because I had not done it initially, and again, Josh had convinced me to do it.
Well, you're worried handing out drugs, right? I mean, and drugs, obviously these are medications, right? But I mean, you're concerned about people not selling stuff in the streets, blood pressure medicines, because you're not handing out. You're not dealing with
for hydrochlorothiazide or something.
Man, I really want to pee. I need some more. But you're not distributing opioids, for instance, because it's just the DEA sort of thing. It makes it complicated, and the lock boxes and all that counts.
I mean, I guess theoretically you could, but don't bother. Don't do it. You open yourself up to so many, bumps if you do that, and theft being a big one,
right? Yeah, people breaking your then you got extra
in fact,
security.
I tell people flat out, we do not carry those. I never want that because people break into your office.
It's like the convenience store, right, where it says we do not have anything over $100, and that access it's all time vault safe. Don't bother robbing our convenience store. All you can steal is a Slurpee, so just go somewhere else.
You really want some Mobic. So anyway, so you need lockable cabinets. You need you get pill bottles. Pill bottles are a penny or two a bottle. I mean, they're very inexpensive. You buy them in bulk, and so basically you create the script in your electronic record system like you would in a normal electronic record system. The difference is you hit print, and then it prints out the label. You've got your little pill bottle. There's two ways of doing it. Largely, many direct primary care docs invest in this automated pill counter that will count them out. You can pour them into the top of the machine, and it has an optical scanner, and it'll pour them out and dispense it into the bottle immediately in the right quantity. And then you just put the cap on and put the Dymo label maker on and hand it to the patient, and they're on their merry way. And the other approach, which is even easier than that, is many of them are dispensed in bottles of 90 or 100 from the dispensaries, and there's many dispensaries, Andameds, Benita. There's several other out there that do direct to physician distribution, and then we dispense to the patient. And if you get Simvastatin 90 and it's $1.50, you can technically put that price where you think is appropriate. Most direct primary care docs do between 10 and 20% upcharge, not because you make money on it, but that covers the cost of the bottle, of the Dymo label maker, and things of that sort. So you're basically not having a loss. And that's so important because that now has created a value for that patient. That patient would, for a 3-month supply, maybe was going to spend $30. Now they spent $2. You've wiped out at least $28 of expense, which partially is covering your.
And that's only one medication, right? Someone's on 3 medicines now. Maybe you've paid for the membership, because a lot of these people, probably most people have some sort of coverage, right? Yeah. On some level, right?
Yeah. I encourage them to, because we can do a lot of things, but if somebody needs an appendectomy, we can't.
You don't do that in the office?
Yeah, I had somebody try to convince me to do a cath, and I strongly advised him against me doing that. But he didn't understand the nuance of there's a difference between types of doctor. But and his $39 membership didn't cover cardiac cath. But we encourage people have some sort of coverage. A surprising number don't, so which really shows there's a problem in our healthcare system when so many people are bare up.
And we're a Medicaid expansion state, right? We should technically have as easy coverage as you can get anywhere in the country.
Well, I have a lot of Medicaid patients, which tells you the value of Medicaid if it's not providing the services that it purports to do. I mean, we have a lot of people who pay more on top of Medicaid. People who are already economically disadvantaged who say that extra $39, $49 a month based on age, that's worth it because I can't see a doc anyway with Medicaid. At least now I can see one, or they'll wait 6 months out until I could see one anyway. So they should have some form of coverage. Christian health sharing, and there's actually versions that you don't even have to be Christian to use, are a wonderful option for people who don't have a lot of pre-existing conditions. Relatively inexpensive, high deductible plans are a great idea because you're going to pay cash anyway under that model. It's just called a deductible, but really that means that's a fancy way of saying that you are paying for your care up until some set amount, in which case your insurance company may help contribute a portion to a false price. We just say, we're upfront, we'll say, we'll give you a better price from the get-go. You just pay us directly and instead of pretending not to pay for it, even though you are paying for it in your deductible. And we give them a better price. Usually it's 90% cheaper than what they would have gotten anyway. And if you think about it, many insurance companies pay 20% of your cost. Well, if we're 90% cheaper, i.e. 10%, their copay was twice as much as they could have gotten it from us without the insurance company involved at all. So they usually save money even over their copayments.
The other benefit you provide is discounts, right?
Yep. So working with local imaging. So there's a huge value you have as a doctor to talk to other doctors in the area. Doctors tend to be nice to each other. When we, in regards to that, we totally second guess each other on diagnoses. But in the sense that,
right, and the radiologist never makes a diagnosis. It could be this or it could be that.
All over the place. But go to your local imaging center. If you have one through a hospital, it's hard to negotiate with them. They get wonderful deals by not having transparent pricing. But if you have a private imaging center, and some hospitals will work with you, but if you've got a private imaging center, go to them and say, hey, if I send people to you who are willing to pay cash right up front, can you give them a good price? And most will. And then we get rid of the fallacy that MRIs are $5,000, and in our area, you can get MRIs as low as $270.
And that's with the reading. Is that with the CD too?
Professional and technical. Yeah. They'll give you actually not a CD, a little.
Do you have the patients pay you and then you pay the facility?
Some do. We don't do that in our. Some DPCs do that. Ours is a little different. We actually, which is really nice. We took ourselves out of that. We got them to agree to give these wonderful pricing and not involve us. So and there's some legal things around it called prompt pay discount, I believe. So basically, if you pay at the time of service, anybody could theoretically get that price that they're giving to their cash pay patients. Well, but if you think about it, no insurance company pays immediately. So that ends up really meaning only the people who are paying at the time of the service get that kind of discount. And because that's less hassle for the radiologist too, they do a service, immediately the money's in their pocket. They love it too, so they're able to give good rates.
Right, because you're kind of doing direct primary care, at least with a transaction.
Direct radiology care.
They don't have to use their back office and coding. 70% of primary care is overhead, right?
Yeah, that's probably right. I used to think it was about 50%, but yeah, you're probably right because I know that my costs dropped far more than 50%. I never quantified it exactly, but yeah, it's probably closer to 70%.
So that's pretty much it.
Well, labs too.
Oh, right, the labs too, right.
Too, yeah.
You have your own laboratory phlebotomist. You have all kinds of people working there, right?
Yeah, so we got real clever. We had the lab pay for our phlebotomist, so we don't even pay the phlebotomist. So we have
the phlebotomist comes to your office.
The phlebotomist comes to our office a couple times a week. There are labs that will be willing to work with you. Quest, LabCorp both work with direct primary care doctors. Though I found the best pricing to be through other places like Vista or True Health Diagnostics. Reach out to them and ask if they'll give you. Most of them will be more than happy to try to acquire as much business as you can give them, and many of them will give you really good rates on the labs, so you get these people who are paying cash for their care. Now that's a little different. That's we're act as a financial intermediary on those. So in those cases, we order labs for them. They do charge us as the doctor. We pay them, but then we charge the patient. We basically act as a financial pass-through. They have to pay us at the time they do it, because otherwise, if they renege on a lab fee, we would eat that. And since we don't make money on that, we can't be eating that kind of expense.
So patients are where you order the CBC and are being charged $2 right now before the lab is drawn.
Yeah, exactly. So we have them come in a couple days a week, and they come in on those days, and a CBC I think is about $3.50. Actually, that's with the 3% markup to cover the transaction fee of the credit card. So there is a credit card transaction fee when you do that. So remember to incorporate that into your pricing structure. But we don't make money on that. People are just unthrilled. I mean, I have one example. I'm a really weird person. I collect medical bills for a hobby, and I had one gentleman who paid $1,100 to a local university hospital in our area, and he came to me after getting shocked because he just went over there with his insurance card and the order. They got an $1,100 charge that he had to pay because it went to his deductible. Came to me and said, how much would that have been? And it would have been around $90-some. Or no, actually, I think it was $106. $106. So it was, again, 90% cheaper. So he would have saved essentially $1,000 on one blood draw by just getting more rational pricing, which would have paid for us for years. One blood draw, he could have seen us for years with the price difference.
It's an incredible thing that those savings are out there.
Yeah.
I don't know how to explain how it happened. It's hard to imagine you can get personalized care for so much less money. It's kind of hard to explain how we just got here with prices.
And I think it's interesting, too, because you're talking about, it's amazing, these prices. And it was amazing to me. In fact, it's still kind of fun to, play around on these websites that our distributors' websites of the meds and stuff and go, oh, wow, that's this? Oh, that's so fun. I'm going to click on that and buy some of that. And we stock up our pharmacy, and it's wonderful to get 1,000 lisinopril, like you said, in $8.99, for 1,000. So it's not a penny a pill. It's less than a penny a pill. And recently I was giving a lecture, and one of the drugs we priced out, I think it was actually lisinopril at that point, we realized that a month of it, so 30 pills, we could dispense to the patient for 24 cents. Which, when you think about that, I was telling him, I said, listen, that means we can treat hypertension, one of the leading causes of premature preventable death in the United States, for an entire month for less than the cost of a single gumball. Because, if you go to Big Boy or something, you got the gumball machine there, drop in a quarter. Well, you could have had a month of blood pressure pills for the same.
To be fair, it's a bit tastier.
Yeah, it is. Yeah, and it is delicious. And I can't say lisinopril is, but.
Now, those are the things kind of hard to wrap your head around. Where we are when we talk about solutions, we're not really talking about solutions, right? I think we're trying to add quality metrics, algorithms. I was talking about this in an earlier show. We're treating people like they're in an assembly line and the same, but they're not. Everyone's different. Everyone responds differently to drugs. They're different ages, size. It's not like they're all built the same and parts are in the same place. You just can't put them all in an algorithm and treat them that way.
Yeah, well, so why algorithm, right? Why algorithms? When I'm sure we're about the same age. When I trained in the 90s, algorithms were just coming into vogue, and it was kind of funny because at the time they had all these disclaimers on it. Said, this is not to circumvent clinicians' judgment. This is to be a tool to assist with complex decision making. Numerous disclaimers. This is never to trump the doctor. Well, now they're mandated. They're not an option anymore. They're mandated. And the question is, what happened there? And it was based on false financial beliefs. Well, MRIs are expensive. So, right, they're $5,000. Or, in 2014 in the state of Michigan, I think the average price on an MRI in the state of Michigan was $3,500. I just told you that's not true, that you can get them for as low as $270. So if you have a severe back pain, by algorithm, even if you deem it's the appropriate first test to do, and obviously, it's not in all situations, but you can't order the MRI. You must order the X-ray first because MRIs are expensive.
And the X-ray is useless for the most part, right?
X-ray may be useless in that situation, absolutely. So, but we've just established that's based on a false pretense, that the MRI is expensive, therefore we must control the doctor's behavior and make them order things in a different way. So when the X-ray is frequently billed at $350, which is more than the MRI actually costs a person. So now we should get to the point where the doctor can have an open discussion with the patient. Say, well, the MRI is probably a little more useful. It's $270, but you're $270. The X-rays now, we get those better priced too. They're about $45, and maybe they're adequate. But maybe for a more reasonable price, that extra $200 is worth it to you to go right to the more effective study. What do you want to do? We don't have that option under the insurance model. We have that option under direct primary care, and that's a beautiful thing.
Well, we'll have to wrap it up here, Chad. I want to thank you a lot for coming on and going through how you get this direct primary care thing started, whether you're a resident or an established physician. Obviously, a lot of resources we talked about during the show, a ton of them. Those can all be found on the show notes page, which will be at www.theparadox.com/004. Or you can just go to the website. You can search on the episodes. It's been a great discussion and learning about how direct primary care not only just changed your life, but how it really can transform, I think, the care for patients. So once again, thanks for being on the show. And best of luck to you with your practice and your new partner. And continued success in the direct primary care field.
It was a pleasure. Thanks for having me.
Thanks for listening to The Paradox. If you like what the doc is doing, please subscribe and leave a review on iTunes or Stitcher. and share the show with your friends. Become a supporting listener to get access to special bonuses at patreon.com/The Paradox. Show notes can be found at theparadox.com.
Recording issue, but it looks like it's fine now. Just the recording seemed to stop for a little bit. It's going now. That's the beauty. I can cut this out anytime. Right?
And every word I said was gold. I mean, no.
It was solid. I mean, that was some really solid commentary there. I hope we didn't lose all of it.
Well, I think we could go for hours. It'd be fun. It's fun BSing.
Okay.